Good morning to all. Very good morning to all, and I hope you're able to hear me and see me. You can see the PPT, I mean. Uh, so today's topic, I have decided to discuss two topics, which are short topics, which each take around 25 minutes. One is infections in transplant recipients, that is solid organ transplant, and hematopoietic stem cell transplant, that is bone marrow transplant. So this is one topic which I am covering. Then I am also going to overview needle stick injury, that is occupational injuries in healthcare settings. Two very important topics for your exams, especially for your PG entrance exams. These topics are very important. Of course, they are important as short notes in some of your in your semester exams also. Now, so let's begin with infections in transplant recipients, that is solid organ transplant recipients, and hematopoietic stem cell transplant (HSCT) recipients. Now, when we talk of organ transplantation, we have two forms of organ transplantation. Solid organ transplantation, in which the allograft or the organ which is being transplanted is a solid organ like the kidney, liver, heart, lung, intestine, kidney, pancreas combined, heart, lung combined, etc. The other transplant is the hematopoietic stem cell transplantation, which is almost equivalent to bone marrow transplantation with slight difference. I'll discuss the terminologies down the line, which could be allogenic, which from some other human being, or autologous, when your own bone marrow stored cells are used later. Again, in solid organ transplant also, it's of two types: cadaveric, wherein a dead body, the organs from a dead body are used for transplantation, and living donor, where a living person donates part of his organ for another human being to save his life. So, with this introduction, let's begin to solid organ transplantation, SOT. Now, solid organ transplantation is performed for end-stage organ disease, when the organ is beyond function and repair. And it could be living donor or cadaveric, as I discussed in a minute back. Many organs now are in the list of solid organ transplantation, and it's a common procedure in most parts of the world. In India, in AIIMS, we have been doing liver transplant, kidney transplant, marrow transplant for decades now, and it's a common procedure throughout the world now. When you talk about solid organ transplantation, the time scale of solid organ transplantation is known as, by the scientist Rubin, is the Rubin time scale. So once you have a person with an end stage disease, say a liver disease or a kidney disease, and he now receives a new kidney or a part of a liver from another human being, in that situation, once a transplant is done, then the timeline of what happens later, of complications, infections, which may happen, not always, but will happen in some patients, is divided into three categories. First, the first 1 month, the 1 month to 6 months, that is month 2 onwards till 6 months, and timeline more than 6 months. Now, in the first month, what do you expect after a transplantation? It's usually surgical complications, technical complications related to the transplant, or nosocomial infections, hospital-acquired infections like staphylococcus, infections of the wound site, etc. So, or a vascular catheter infection. So, these are usual complications which happen in any surgery, or are complications associated with any procedure, right? But the main thing is this intermediate period, 1 month to 6 months, that is month 2, 3, 4, 5, and 6. So in these 5 months, opportunistic infections are the most common source of problem and morbidity and mortality in these solid organ transplant patients. Of the various organisms, viruses, fungi, parasites, bacteria, many of them can be opportunistic in these situations. And the most common are viruses, and the most common alone single agent is the human cytomegalovirus. This is the most uh, troublesome agent for a transplant recipient. Other herpes viruses, because all of them are latent in the body, herpes viruses, so they can reactivate and lead to disease. Polyoma viruses, especially BK virus, especially in renal transplant, is a big problem. CMV is a problem in any transplant. All the other herpes viruses also in any transplant. BK virus is peculiarly to renal transplant because it's sitting in the kidney. Then you have any transplant recipient can have candidemia, aspergillus, pneumocystis, fungal infections. Parasites, protozoa, toxoplasma gondii could be a big problem. amongst the parasites, strongyloides can be a big problem. Cryptosporidium is an emerging, the coccidian parasites, especially Cryptoisospora and Cryptosporidium. I'll be discussing it down the line. In bacteria, nocardia, and many other bacteria actually. But these are the unique ones which are seen much more in transplant recipients than other populations. After 6 months, the story totally changes, because now the patient has, the transplant organ has been accepted. Now the patient is more like any other regular patient. His immunosuppressive drugs have stopped or have tapered down to very low doses. So now they are at risk of, no longer to risk of peculiar complications like these. And then their infections are what you see in any general population person. So then they get community acquired infections like anybody else, like you and me. Okay, so this is called the Rubin time scale. Now let's review the organisms one by one. This is the Rubin's time scale from Harrison, which is much more complicated. I made it easy for you here. This is the simple chart for your undergraduate level. You should just remember this chart. Okay. Now, on the other hand, we have hematopoietic stem cell transplantation. Here, it's nothing but the intravenous delivery of hematopoietic stem cells to a recipient whose hematopoietic immune systems have been ablated, destroyed, or altered by cytotoxic or immunosuppressive drugs. So, you have to give him a new marrow. Okay, because there's some problem in his marrow, so you have to give him or her a new fresh stem cells from a healthy bone marrow individual, so that this person can use and eventually be able to adapt and grow, live with those stem cells which he has acquired now. So first you have to ablate or to destroy his own marrow, so that because if it's a bone marrow cancer, for example, there are many situations where the bone marrow is beyond giving normal hematopoietic stem cells, so you have to replace it. So first, before you do a hematopoietic stem cell transplant or HSCT, you have to ablate or destroy the person's own marrow which is no longer functioning fully. And this is called the by a group of cocktail of drugs, and this regimen is known as a conditioning regimen, which is given 4 to 10 days prior to the bone marrow transplant or hematopoietic stem cell transplantation. So, what is the source of the hematopoietic stem cells? It could be the bone marrow, the richest source. It could be, you can take peripheral blood from a human being, and from them, which has very little of these stem cells, very less stem cells, you can stimulate this peripheral blood by filgastrin in special conditions of the lab, and by giving filgastrin, that is a granulocyte colony stimulating factor, and then get some stem cells from there. Or you can use umbilical cord blood, because umbilical cord blood has a higher amount of stem cells compared to peripheral blood. But of course, the bone marrow is the best. So you can use any of these three sources. Bone marrow, if you're using purely the bone marrow, then it's called the bone marrow transplant. Actually, all of them are giving stem cells. That's why the generic term is hematopoietic stem cell transplantation. Okay. But since bone marrow is the most common source of these hematopoietic stem cells, it's equivalent almost to BMT, same as HSCT. But actually, these two are not BMTs. You are using peripheral blood or cord blood and stimulating that blood and using it to grow stem cells, and then you're using those stem cells. Whereas in bone marrow, you're directly using a high amount of stem cells. Ultimately, the aim is to give stem cells to the patient. After the conditioning regimen is over, then the patient is intravenously given hematopoietic stem cells. And then you're giving time for them to grow and adapt in the new human being or host. Now, why do you need a hematopoietic stem cell transplant? It could be bone marrow failure diseases like aplastic anemia, Fanconi's anemia. It could be hematological malignancies or tumors, leukemias, lymphomas, myelomas, anemias which are severe and not treatable with standard therapy, hemoglobinopathies, thalassemias, immunodeficiencies which are severe, may require a bone marrow transplant. Some inborn errors of metabolism ultimately need a bone marrow transplant, like chronic granulomatous disease, Hurler syndrome. And then you have solid tumors, even immunodeficiency disorders, here. And solid tumors like neuroblastoma, germ cell tumors. So, again, like the Rubin time scale in solid organ transplants I discussed a few minutes back, here also the hematopoietic stem cell transplant also has a timeline. The pre-engraftment period, the early post-engraftment period, and the late post-engraftment period. Pre is before the stem cells have been engrafted in the host. So this begins with conditioning therapy, which I discussed, which is given 4 to 10 days before transplantation and continues for up to approximately 30 days or 1 month. plus minus 10 days after the you have given IV the stem cells. And in this phase, since the patient's own marrow has been ablated and the new marrow has not yet taken over, so this is hence called the pre-engraftment period. And here, profound neutropenia and lymphopenia is very common, and bacterial infections are the commonest. Also, although other infections can also happen, but bacterial infections are typically much more common. In the early post-engraftment period, when the immunosuppression drugs have also been the transplantist, the stem cells are trying to take in the human being, and the immunosuppressive drugs are also being given to suppress that up to day 100, from day 30 to day 100. So day 31 to 100 after is the early post-engraftment period, when early B and T cells are functional recovery is beginning, and reconstitution of the T cells, it takes around since reconstituting T cells takes some, they are not fully normal, they are abnormal in the beginning, their functions are not so full. So that's why there are at this phase the patient is at risk of again the similar virus, the organisms are discussed, whether it's cytomegalovirus, other herpes viruses. Many of these organisms cause problems in this phase only, like it was in the Rubin time scale in the middle phase, 1 to 6 months. Similar organisms and almost the same organisms, but with different severities may cause infections here. Late post-engraftment periods begins from day 100, and it takes 18 months to 36 months, up to 1.5 to 3 years for the patient to be totally normal. So recovery time is slower and takes longer in hematopoietic stem cell transplantation. So this table tells you in which phase which organisms are there. So before we go on to the organisms in brief, let's discuss two important pioneers from our institution who have contributed tremendously to transplantation in India. Professor P. Venugopal, all of us know, he was the pioneer of cardiac surgery in India, and he did his MBBS, MS, and MCH from AIIMS only. And in August 1994, he performed the first heart transplantation of India on patient Devi Ram with dilated cardiomyopathy. And he also was the pioneer to start stem cell therapy in our country. He played an important role in cardiac surgery in India. Next to follow is Dr. Arvinder Singh Soin. Dr. Soin is a pioneer of liver transplantation in the world. He did his MBBS and MS from AIIMS, and then he went on to do his FRCS from Cambridge. He holds till now also the record for the second highest liver transplantation in the world. And presently he was in AIIMS, then he now presently I think he's in Gangaram Hospital, and where he does 1 to 2 transplants daily. And he has crossed more than 1,500 even more transplantations of liver in the world, second highest in the world. He's just 1 or 200 behind the highest in the US, and he's a pioneer of liver transplantation in our country, in the world in fact. Now, coming to the herpes viruses, which is the biggest group of viruses which create problems in transplant recipients. We have discussed these viruses in brief, and this table has been discussed with you in the herpes class. So, human cytomegalovirus, as we know, is a ubiquitous virus. With our prevalence in India is very high because the virus, once acquired in infancy, becomes latent, and once the immune system goes down in transplant recipients, whether it's solid organ transplant or hematopoietic stem cell transplant, it leads to infections in these populations. We have discussed many of these infections in earlier classes. We have discussed congenital CMV, we have discussed IM-like syndrome in the exanthem class, and HIV has been discussed as a separate class. So infections in solid organ transplantation patients, the virus sits latently in the most important cell in which the CMV becomes latent is the monocyte-derived dendritic cell precursors in the bone marrow. It also sits in the monocytes, endothelial cells, epithelial cells of the kidney and the salivary glands. So it can reactivate from anywhere, and most commonly it reactivates from the bone marrow in the transplant setting, in either SOT or HSCT, and it's the commonest viral pathogen causing infection in transplant recipients. Of all bacteria, viruses, parasites, fungi put together, CMV alone is the biggest problem and offender. 75% of transplant recipients may develop CMV as an asymptomatic subclinical infection or a symptomatic disease. And so what happens is, before you do a transplantation, you have to, the donor and the recipients IgG CMV status is taken, is measured, or considered to stratify these patients into low or high risk of post-transplant infections. So what we do is the D is the donor, R is the recipient. They do the IgG by ELISA, CMV, human cytomegalovirus IgG, anti-HCMV IgG test. And based on whether the donor and the recipient are both positive, both negative, or either positive or negative. Now, if both the donor and the recipient are negative, the risk, since both of them don't have latent virus in their body, because they're otherwise, if you have the virus acquired in your body, you will be seropositive by IgG or CMV. So in this case, the risk of CMV is minimal to low. You may acquire it from blood transfusion, which you have acquired had after a transplantation, isn't it? So the risk is not zero; it is low. If the donor is negative, but the recipient is already having the virus in the body, risk is still intermediate. If both are positive, the risk still remains intermediate because the recipient ultimately in both the situations had the CMV virus in his body latently in the bone marrow and other cells of the body. But if the donor is positive and recipient is negative, it's better not to use such a donor. But if you have no other donor, then you can use. But the risk of CMV is very high because the recipient, pehle se he was negative, and the donor is giving him the virus via the organ or via the stem cells, right? So, based on the stratification of D and R status of the CMV IgG, the prophylaxis of CMV and treatment is planned accordingly. So, what are the clinical effects of CMV in this in solid organ transplantation, and also similar things in the bone marrow transplantation? One is CMV syndrome. CMV syndrome is a constellation of features called as fever, myalgia, arthralgia, flu-like illness, leukopenia, thrombocytopenia, and is a very peculiar situation which is diagnosed by clinical and laboratory features. Tissue invasive disease, where the CMV causes uh, tissue invasive disease, like in GI treatment cause colitis, pneumonitis, hepatitis, encephalitis or meningoencephalitis or meningitis, retinitis, nephritis, pancreatitis, myocarditis. Any of these, of which most common tissue invasive disease in transplantation recipients is colitis by the GI involvement. These are direct effects of CMV by the virus itself. Indirectly, the virus replicating in the body can contribute to acute or chronic allograft rejection, and it may also be in stem cell transplantation patients, HSCT, sorry. It can lead to graft versus host disease. This you will be taught in pathology in detail. Opportunistic infections is what I'm talking about, can happen with CMV. So CMV alone is a risk factor for other opportunistic infections. CMV itself is an opportunistic infection, but it also predisposes to other opportunistic infections in these hosts. And it also contributes to immunosenescence or aging of the immune system if it replicates for long times, high levels in individuals. How do we diagnose CMV? Before we have a transplant, what are the tests we need to do before the transplantation? As far as CMV is concerned, an IgG ELISA for both the donor and recipient is compulsory and is important. And for the patient, a baseline viral load, that is real-time PCR for viral load, of the patient who is receiving the transplant should be done just prior to the transplantation, so that we know that he is negative or has some viral load of CMV, so that further therapy or treatment or prophylaxis can be planned accordingly. So, a rapid test is to do an antigen detection, that is a PP65 antigen of the virus can be detected by immunofluorescence test, but this test is less commonly done now because of the issue of better tests like PCR being available. The standard of care now after transplantation is to monitor the patient's viral load by real-time PCR. If there is a tissue invasive disease and you are planning a biopsy, then in that case the tissue can be examined by histopathology, and AIIMS inclusion bodies, which I described in the congenital CMV class, may be seen in the organs, or you can demonstrate the antigens of this virus by immunohistochemistry. These tests are done by the pathologist. Viral isolation from any of these samples, which the patient, if it's CSF from encephalitis, if it's tissue, say colonic tissue in colitis, etc., you can grow the virus from blood or other such samples, and in lung fibroblasts, diploid cells, like for any other CMV infection disease, but it takes time and it's useful only in research purposes. IgM has a limit, serology IgM, I mean, not IgG. IgG is a very important test pre-transplantation. IgM test after transplantation is not very useful because usually most of these patients are severely immunocompromised and they're receiving immunosuppressive drugs, and IgM may not develop in such situations. How do you, now a word about prophylaxis and management. The drugs which are used for prophylaxis. Once the transplant happens, many patients are put on prophylaxis with valganciclovir or valacyclovir. And then two things are done later. Either a preemptive therapy approach is done or a treatment approach is done. Preemptive therapy means that once you have had a transplant and the patient now is recovering after transplantation, you monitor the viral load every weekly or 15 days, or earlier or even some centers do it monthly if the risk is low. Risk is high, then you do it at more frequent intervals, and every center has its own regimen. So here you monitor the viral load, and once the viral load crosses a threshold, which every center has its cutoff, say 10 to power, usually it's around 10 to power 4 copies per ml. It could be 10 to power 3 or 10 to power 5 plus minus 1 log, depending on the global epidemiology and the risk of the patient. So patient has no disease or features of CMV, but you're monitoring the viral load, and once it crosses 10 to power 4, for example, the usual cutoff for many centers, copies per ml of the viral load in the blood, you start giving therapy, treatment. Presume even if there is no disease by the CMV evident clinically, you just give him treatment doses of ganciclovir, foscarnet, or cidofovir. Whereas treatment means when the patient develops signs and symptoms of CMV disease, any of those which I described, any of these are described here, direct or indirect disease effects of CMV, you suspect CMV as a cause there. Then you order investigations and start treatment directly by again the same drugs, ganciclovir, foscarnet, or cidofovir. Drug of choice is ganciclovir IV. If it doesn't work, second line is foscarnet, and the third line is cidofovir. So preemptive therapy is not giving treatment directly, but monitoring the viral load, and once it crosses a threshold, say 10 to the power 4 copies per ml in the blood, you start giving treatment, and do not otherwise. In treatment, you don't give treatment just by viral load. Whether you're monitoring viral load or not, usually you are. You give treatment based on evidence of CMV disease by clinical features, signs and symptoms. That's the difference between preemptive therapy and treatment. So once the patient undergoes a transplantation, usually prophylaxis by valganciclovir is started. And let's see one actual case from our institution. The patient underwent a renal transplantation in July, and till September, his CMV, there was no viral load. There was no CMV virus in the body, but on 15 September the viral load was detected, and it rose to very high levels within a few weeks. While ganciclovir was stopped, and ganciclovir was started when the threshold increased to 4.4 10 to the power 4 copies per ml, the threshold for the center. And then the viral load started decreasing. But sadly, most patients are okay with this. But sadly, in this patient, what happened is after some weeks, his viral load again started increasing, and now what will you suspect? You may have to rule out resistance to this drug, which may have developed in this individual. So with that we come to what is resistance to CMV. CMV resistance happens due to changes in two gene regions of the virus: the UL97 gene, that is a phosphotransferase, and the UL54, which is a polymerase of the virus. And various signature mutations have been described with different drugs. Okay. So you don't have to remember the mutations, you just should know that UL97 and UL54 regions of the CMV virus are highly associated with mutations to these antiviral drugs which we are using for CMV. Coming to Epstein-Barr virus, the next virus. Now these viruses all I have discussed in brief with you, so I'm not taking more than a minute for these viruses. EBV causes a lot of diseases. It's an oncogenic virus. It also has our seroprevalence in EBV is around 80 to 90% in most parts of the world, including our country. And it causes IM, it causes Burkitt's lymphoma. What I'm discussing today, it causes oral hairy leukoplakia in HIV, nasopharyngeal carcinoma in some oriental countries, in northeastern and Chinese descent people are more prone. What I'm discussing today is PTLDs, or post-transplant lymphoproliferative disease. PTLD is nothing but EBV-induced spectrum of lymphoproliferative diseases following SOT or HSCT, and it is due to lack of T-cell immunosurveillance to EBV because of immunosuppression. It can be seen in both solid organ transplantation and bone marrow transplantation, and it is higher in children than adults. And so, for example, it's very high in both the populations, and it's highest in heart or lung transplantation, as you can see here. So PTLD is nothing but early monomorphic or polymorphic lymphomas, which are benign to aggressive lymphomas, which are usually B cell, but they can also be T cell lymphomas. They could be non-Hodgkin's or Hodgkin's type lymphomas, usually NHLs, and the common ones are diffuse large B cell lymphoma, plasma Burkitt's lymphoma, peripheral T cell lymphoma. Or early lesions are very simple hyperplasias, or IM-like lesions can also develop, which are benign. So the treatment of these, these have been taught to you in pathology, right? So they usually happen 2 months after BMT and 6 months after solid organ transplantation. They may have non-specific features of fever of unknown origin, malaise, anorexia, and the lymphoma presents as a rapidly enlarging mass or space-occupying lesion at the grafted site or at any lymph node, or it may fill the marrow space and lead to a marrocytic anemia, or at extranodal sites like airways, intestines, and cause obstruction. So treatment is basically okay. How do you monitor PTLDs? Imaging is important to see them. Biopsy is important to diagnose them. And if you suspect EBV as the cause of that space occupying lesion, then monitoring the viral load actually helps because it helps like a tumor marker. If once chemotherapy is working, the viral load will come down of EBV. So it's very high in the beginning, and you can actually monitor EBV viral load. Helps in monitoring response to chemotherapy and surgery. Reduction of immunosuppression is very important. Rituximab, that is the antibody to CD20, which is used by the virus to enter, is used. It's for immature T cells, monoclonal antibody inhibitor. Rituximab is used, and chemotherapy, radiotherapy primarily for the tumor is important. I've discussed varicella zoster virus, which causes chickenpox, and which we all know as a rash evolving into macules, papules, vesicles, and crusting. This may happen if the primary infection happens after transplantation, but the most common thing is zoster or shingles. Because of immunosuppression, shingles can happen anywhere in the body. It can be very severe in these transplant recipients. So I have discussed zoster with you earlier. Treatment is with acyclovir, and aspirin should not be used for the risk of Reye syndrome. It's a clinical diagnosis, but you may require a Zank test or PCR in suspect situations. But a simple Zank test is very useful bedside test in these patients. Immunization with varicella or zoster should be considered prior to transplantation, depending on the situation. Now, BK polyomavirus are a very important group of viruses which are important in renal transplant recipients. Now, before we go on to BK polyomavirus, a little bit about these viruses. Polyomaviruses are double-strand DNA viruses, and we all acquire this virus early in infancy without any major sequelae. In fact, just like many viruses, the seroprevalence in healthy individuals and adults is more than 80% with BK virus, and it's shed commonly in the urine, just like CMV is shed in the saliva in many of us. And the polyomaviruses are of 4 major types clinically, which are clinical disease they cause. BK polyomavirus, which I'm discussing now, is associated with renal transplant complications I'm coming to, which I'll discuss. These 3 I'll discuss today. That's the class today. In HIV and in severely immunocompromised populations, JC virus causes PML, or progressive multifocal leukoencephalopathy. The Merkel cell carcinoma is caused by the Merkel cell polyomavirus, which is a neuroendocrine skin tumor. And a peculiar and rare skin condition is trichodysplasia spinulosa, especially in the immunocompromised. It's more common, is caused by the trichodysplasia spinulosa polyomavirus. So these are the 4 polyomaviruses which are important for human disease. They are relatively rare, but in transplant settings, BK virus is a very problematic situation, especially in the renal transplant. So I'll discuss now, and in bone marrow transplant, this same virus, BK virus, causes hemorrhagic cystitis. So let's discuss these 2. So once it enters the body via ganglioside receptors in the body, it remains as an episomal without integration into in the human host, and it establishes a persistent infection, if not a latent infection. It persists in an episome and reactivates periodically, and causes it can be detected in the body fluids. In transplant recipients, renal transplant recipients especially, 30 to 40 of such transplant recipients may have a viriuria. So the virus is shed in the urine post-renal transplant in the urine, and around 10 to 20% of these renal transplant recipients have a viremia, and those who have a viremia, the virus comes from the kidney. It's sitting in the kidney cells, and it is shed in the urine in few of these renal transplant patients. In some, it spills over into the blood, and in 2 to 5% of those in patients, it actually leads to BK1 or BK virus associated nephropathy, which contributes to graft failure and may fail the entire procedure of what you have done, the surgery you have done for renal transplantation. There's no antiviral here. Like in CMV, you had ganciclovir, or you had other aciclovir for varicella zoster. Here you have nothing. So only reduction of immunosuppression is the only armamentarium we have as of now. The other group of patients is the stem cell transplant patients, in which the same virus, BK virus, causes hemorrhagic cystitis. Around 10% of patients may have a mild to severe hemorrhagic cystitis, and the typical timeline is 2 weeks after the bone marrow transplantation, or HSCT. Features like dysuria, frequency, urgency, suprapubic pain, hematuria may be seen in severe cases. But remember, hemorrhagic cystitis is not just caused by BK virus. Adenovirus 1135 can also cause the same situation in transplant recipients. Chemotherapy, drugs can induce, drug-induced chemotherapy. Drugs like cyclophosphamide, busulfan can cause cystitis. Radiation of the pelvis can also cause hemorrhagic cystitis. So all these things have to be taken into clinical account when you are discussing the differential diagnosis of such a patient. How do you diagnose BK virus? You can use urine, blood, and plasma tissue like renal biopsy. In the urine, you can see decoy cells, which are of various types. These are the cells infected by the BK virus, and they typical is a large. These are viruses or DNA viruses that replicate in the nucleus. A huge nucleus occupying the urothelial cell with different. You can see here. So, and they replicate in these cells, and a group of such constellation of cells, of such infected cells on electron microscopy is called the Hoffin. So, urinary Hoffin is nothing but a collection of BK viral particles in the urine. So, in urine cytology, decoy cells can be seen by staining by HNE, by PAPS staining, and Hoffin detection can be done by electron microscopy in urine sediment, which is aggregates of BK virus particles in the urine. They look like urinary casts. PCR is the standard in urine and serum for monitoring these patients. The cutoff are established for this. 10 to the power 7 in the urine and more than 10 to the power 4 in the blood copies per ml is significant and should be taken seriously. Histopathology, immunohistochemistry can be used by pathologists for this virus. Now, I'll just very briefly discuss fungi in transplant, because I'm discussing the entire spectrum of transplant infections. Now, if you remember the fungal cell wall, so they have outer layer of manoproteins, then you have a cross-linking of beta-1,3 and beta-1,6 glucans with glucose monomers. This is the so first layer is manoproteins of various types. Then the glucans, beta-1,3 and beta-1,6 cross links. You can see these crosses. One is beta-1,3, one is 1,6 with glucose. And then you have a layer of chitin. This is chitin. And then you have the plasma membrane, which is a phospholipid bilayer. Now, the various antifungal drugs which we have now act at various levels here. One group of drugs, the echinocandins. Echinocandins are capsofungin, micafungin, anidulafungin, etc. Caspo, mica, and anidulafungins, the echinocandins, inhibit beta-glucans here. So they inhibit these beta-1,3, beta-1,6 glucan synthesis. So beta-glucans in the cell wall are inhibited by the echinocandins, that is caspo, mica, and anidulafungin. The other group of drugs, most of the other group of drugs inhibit here at the cell membrane level. So after the chitin layer, you have the phospholipid bilayer, which contains ergosterol. Polyenes like amphotericin B and nystatin directly bind to ergosterol, damaging the ergosterol, causing pores in the membrane and leaking out of the cell and cell death of the fungus. The ergosterol, as we all know, is formed from squalene. You have studied this in biochemistry. Squalene to lanosterol is by squalene epoxidase, and then lanosterol to ergosterol is by 1,14 alpha demethylase. So the other two drugs inhibit these enzymes. Polyenes, amphotericin directly bind to ergosterol here of the cell membrane, whereas azoles like fluconazole, voriconazole, and posaconazole inhibit 14-alpha demethylase, this enzyme which inhibits, which converts LANO to ergosterol. Whereas squalene epoxidase is inhibited by terbinafine. Terbinafine is used for dermatophytes, so I'm not discussing that anymore. So, what three important drugs you should know is echinocandins at the cell wall, inhibiting beta-1,3-glucan, caspo, mica, and anidulafungin. Polyenes directly bind to ergosterol. Azoles, fluco, voricona, and posaconazole inhibit 14-alpha demethylase. Now, one minute on each fungus. Candida. Candida is a yeast-like fungus with various species. Albicans is the most important, but now non-albicans Candida, like Paracillosis, tropicalis. One second. Tropicalis, Paracillosis, Glabrata, Cruzii, Gulerimundi, and now an emerging pathogen Oris. So many of these are normal flora, and predisposing factors like immunodeficiency, like transplant recipients, HIV, diabetes, chemotherapy, steroids, all predisposed to invasive candida infections. In the transplant setting, the most dreaded complication is candidemia. Other forms of candidiasis is meningitis, osteomyelitis, renal abscess, myocarditis can also be seen. The drug of choice for candidemia and invasive candidiasis is caspofungin or micafungin. Okay, caspofungin, micafungin are the echinocandins, these ones, which inhibit the beta-glucans. Aspergillus, like fumigators, is the most important. Aspergillus species are angio-invasive fungi, and in transplant recipients, they cause invasive aspergillosis. By pulmonary disease or CNS involvement rarely is also a dreaded complication, but pulmonary disease is the most common complication of aspergillosis. Diagnosis is by culture. Serogalactomannan assay is an important biomarker for aspergillus. Okay, and PCR, of course. The treatment of choice for aspergillus is voriconazole, or followed by, if not working, amphotericin B. Posaconazole is used for prophylaxis. So voriconazole for treatment IV and posaconazole for prophylaxis are the drug of choice. Voriconazole is this one here, which is an azole inhibiting 14-alpha dimethylase enzyme from LANO to ergo. Pneumocystis, a fungus, which is a very important pathogen in the HIV era, where the CD4 count is below 200, but also in transplant recipients it can cause a pneumonia or it can cause a disseminated infection. Treatment is by the combination of trimethoprim, sulfamethoxazole, atovaquone, clinda, primaquine, penta are also useful. Dapsone with pyrimethamine is a drug of choice for prophylaxis against pneumocystis. Cryptococcus, which causes chronic meningitis, meningoencephalitis in the HIV, can also cause similar things in transplant settings. We have discussed that Cryptococcus is of 4 types and 2 distinct species. Neoformans grubii is serotype A, Neoformans is serotype D, Gattai is Neoformans B and C. In transplant recipients, Neoformans grubii and neoformans are the most dreaded. The treatment of choice is amphotericin with IV flucytosine, followed by oral fluconazole. Among the protozoa and helminths, toxoplasma. We have had a separate class on toxoplasma. In transplant recipients, it causes encephalitis. It's an obligate intracellular parasite with a heterogeneous nature of. Heterogeneous means it has many xenous or animal hosts. Hetero means many. It causes encephalitis typically in the transplant setting. The treatment of choice is trimethoprim plus sulfamethoxazole. Pyrimethamine, sulfadiazine can also be used. Intestinal coccidia, especially Cryptosporidium, Cyclospora, and Cystoisospora are important human pathogens in transplant setting. We all know that Cryptosporidium, the most common species is in humans, is Cryptosporidium hominis, not parvum. Parvum is the next most common. C. hominis is the most common human species, hominis, and then parvum. Wrongly, many books say parvum, that's very wrong. Their oocysts in size in fecal specimens by acid-fast staining, you can see them in the size of 4 to 6 microns around. Slightly bigger in size is Cyclospora caetulensis. Around 8 to 10 microns is the oocyst size, as you can see in this picture on stool samples by acid-fast microscopy. Cystoisospora, which was called isospora briefly earlier, is 20 to 30 nanometers in length, approximately by 50 nanometers in breadth. The average size is given here. You can use PCR also for detection. The drug of choice for cryptosporidium in transplant settings is nitazoxanide. If not useful, then paramomycin with azithro combination is used. For cyclospora and cystoisospora, these two, trimethoprim plus sulfamethoxazole is enough. So with this, we end with this lecture with just a brief about Strongyloides torcoralis, which is the helminth, which is the important organism in transplant settings. Filariform larvae is the infective form. After entering percutaneously, we all know the life cycle. We have had it before. In transplant settings, hyperinfection syndrome can also happen. So it's very important to keep this organism in mind, especially in patients with diarrhea or dysentery in transplant setting. Or even in hyperinfection syndrome, it can disseminate in the whole body. And in this case, both the filariform and the rhabdiform larva are seen in the body fluids. And otherwise, normally in stool, you only see rhabdiform larva as a diagnostic stage. Okay. Treatment is ivermectin or thiabendazole, mebendazole can also be used. This is how it looks like. This is rhabdiform larva in stool in a post-transplant setting, an actual case which I had during my MD here. So with this, I finished transplant infections. If it's okay, I can take 7 more minutes to finish one more topic which we have actually discussed: needle stick injury. Now, we all are at risk of this is the next topic. This is not transplant now. I'm starting a new topic, which I'll finish in 5-7 minutes. Now, occupational exposure to bloodborne viruses is we all can get needle stick injuries during our working environment of the hospital. Whether we are students, interns, residents, or faculty, or consultants, at any stage of life, we can get needle stick injury, wherein we are prone from the blood of from the needle stick, blood, we are able to get some form of bloodborne virus. The 3 important viruses are hepatitis B, hepatitis C, and HIV. All these viruses have been discussed. So I'm only discussing needle stick injury mein kya karna hai. So healthcare worker is anyone who is exposed to a bloodborne pathogen via his work in the workplace, via a injury which is not just needle stick. Any sharp injury can also be leading to we getting exposed to these 3 viruses. So immunization and post-exposure management are very important in this situation. So we can, but usually it's a percutaneous exposure via a needle or a sharp object, but a scalpel blade exposure is also comes under the needle stick injury umbrella. A mucocutaneous exposure via a body fluid or blood via a splash onto the eyes or nasal mucosa or mouth can happen, or a scratch or bite from a human being who has these viruses in his body fluids can also we can get this infection from these sources also. So all this comes under occupational exposure, and needle stick is the most common. So it can happen with these 3 viruses get into our body system via such exposures. So it can happen to anyone: emergency staff, nursing staff, gynecologists, technicians in the lab, physicians, dentists, mortuary staff, interns, anyone can have it. Okay, it can happen anywhere: emergency procedure room, inpatient room, OPD, during use, after the disposal. The person who is collecting these needles, your staff who is collecting the needles, even the laundry guy can have it if there is a scalpel in the linen which has been sent from the ward. Okay, so it can happen to anywhere, even during and after disposal, it can happen to anyone. Now, this is very important. Which viruses are the most risk? Hepatitis B is the most scared of here is HIV, but actually that's the risk is least with HIV. Hepatitis B, if it's a high DNA E antigen positive patient, then the risk is 15 to 30%. And if it's a low DNA or a low E antigen negative patient, then the risk is slightly lower, 5 to 17%. Hepatitis C, the risk is 3 to 10%, lower than B, and it's 0.3% with percutaneous HIV exposure, and 0.09 with a mucosal exposure. So risk of HIV is much less compared to hepatitis B followed by C. Then only HIV comes into picture. So what do you do? Once you have an occupational needle stick injury or any such exposure, you provide care to the site, you determine the risk of exposure, evaluate the source, evaluate the person, and give post-exposure prophylaxis and follow-up testing for hepatitis B, C, and HIV if required. So First thing is to do is to contaminated wound, encourage bleeding, wash with soap and water. Then intact skin, you can wash with soap and water. Eyes, rinse with saline or water. You can't use soap, it will burn. Just use saline or water to rinse with the eyes. Mouth, spit out the fluid and rinse copiously. Don't panic. Don't squeeze the blood from the wound. Squeezing the blood from the wound actually creates inner currents, and the infected blood may actually enter it deep inside. So don't squeeze at all. Don't place a finger into the mouth. Otherwise, you are creating two needle stick injuries. The mucosa is also exposed now. Don't apply disinfectant or bleach alcohol. Just wash with soap and water or simple water, and immediately consult your doctor, the in charge there. The body fluid involved could be blood, serum, plasma, any blood containing body fluid like pericardial, pleural, peritoneal fluid. Also, it depends on how much quantity of blood has gone inside, which determines the risk. What needle was it? Sharp, or it was a hollow bore needle or a sharp needle? Depth of injury, how much the injury went in, the needle went inside, and how much is the viral load of the patient ultimately. Whether the patient was infected but had a low viral load, so the risk is lower. So all these factors determine the outcome. Now, what do you do? What test do? You do from the patient, because you want to know whether the patient is infected or not in the first place. If the patient has none of these viruses, you don't need to worry, right? So, hepatitis B surface antigen for hepatitis B, the serology or third or fourth generation serology for hepatitis C, and HIV serology for HIV, third or fourth generation. So, you do the baseline workup. In case the patient is immunocompromised patient, then you go to viral load of these viruses, because if the patient is immunocompromised, HBsAg is no problem, it's an antigen. It will be detected. But antibody may not be detected if the source patient is immunocompromised. Now, for the exposed healthcare personnel, what do? You do the same test and also do the anti-HBs titer, so that you know your titer of hepatitis B in case you are vaccinated. And of course, if you require follow-up with drugs or antivirals, if at all, you have to monitor yourself for liver function test and CBC routinely. In case of hepatitis B, we know most of us as adults will clear the virus. Some of us will go into chronicity. But if you have a needle stick injury and your source is non-reactive, nothing to worry. So if HBsAg is negative of the source, nothing to worry. Just do your titer, and if it is less than 10, take a vaccine, so that you having the vaccine now, so that for future exposure you don't have any risk. So if the source is negative, nothing to worry. Just take the vaccine if your titer is less. If your source is reactive, then you need to know your titer. And then you may require prophylaxis if your titer is less than 10, right? And then follow-up will be done after baseline at 12 weeks and 14 weeks for hepatitis B. And in case you have been given the vaccine at that time, anti-HBs titers. So I'll just discuss that down the line. So if the exposed person is positive, then if your titer is less than 10, nothing to worry. But if you are a non-responder, means your titer has come below 10 at the moment. Okay, your titer is less than 10 now. You take 1 dose of immunoglobulin of hepatitis B at this dose, 0.06 milliliter per kg, and then also start the vaccination. Or in case you're a total non-responder, you have been given the vaccine twice full courses of the vaccine and you have not responded, which I discussed in the earlier class, then you have to take 2 doses of immunoglobulin. If your titer is less than 10 and the vaccine status of the source of you don't know when you took the vaccine, then you take 1 dose of immunoglobulin and vaccine together, 1 booster. If you're not vaccinated, take 1 dose of immunoglobulin and start the vaccination. So in short, you have to take the immunoglobulin and the vaccine combination depending on the situation. The vaccine is the effective titer is more than 10 IU per L or more than 10 MIU per ml. Hepatitis C virus, we have no vaccine and we have antivirals, but we have no vaccine for this virus. So in this case, we also know that once a person gets infected, most of us become chronically infected. These charts I have discussed in the hepatitis C class. But if your source is non-reactive for hepatitis C, nothing to worry. But if your source patient is reactive, from whom you had a needle stick injury, you have to confirm the patient's RNA now, because he may be antibody positive but may not have RNA. So you have to go for RNA now, and then follow up at 6 weeks, 12 weeks and 24 weeks with antibody and RNA in yourself. In HIV, because there's nothing you can do, you have to just follow up. Because there's no vaccine here. HIV, we don't have a vaccine, but we have antivirals which are useful. So in HIV, we all know this is the acute phase of HIV, when you have acute retroviral syndrome, which may manifest as infection mononucleosis or meningitis, sometimes rarely, or rash with fever, etc. Then you have years of latency, and then you have the stage of constitutional symptoms down the line after a median of 9 years. If your source is non-reactive, nothing to worry. But if your source is reactive, then you have to start PEP immediately. Do your antibody levels now, and then follow up your antibody levels up to 24 weeks, so that to see whether you have acquired HIV or not. And despite taking PEP, you must follow up with HIV serology after starting PEP. Now, what do you do for PEP? First, you classify the exposure as mild, moderate, severe. Mild severe exposure is to mucosa or non-intact skin with small volumes. Moderate exposure is mucosa or non-intact skin with large volumes of blood. And severe exposure is percutaneous, large volumes of blood. So this you can read up from the slides. I'll share the slides with you. Then you classify the exposure as mild, moderate, severe and start therapy based on your status. If the patient was HIV positive and asymptomatic, or HIV positive and symptomatic with features of HIV, or his status is not known. In that case, in either situation, you have to match whether you have to give a 2-drug regimen or a 3-drug regimen. Getting it? So if mild exposure and HIV positive patient is asymptomatic source, just 2-drug regimen. If the patient is severe, exposure is severe, your exposure is severe, and the patient has, then you have to go for a 3-drug regimen. Or usually you may go for no PEP or just at least a 2-drug regimen if the situation, according to the situation of your exposure. So a 2-drug regimen is zidovudine plus lamivudine or stivudine plus lamivudine. Preferred choice is zido with lami. A 3-drug regimen is to add to this 2-drug regimen a protease inhibitor. Lopinavir, ritonavir is the most preferred choice. Others, nelpina, indinavir can also be used. And this has to be used for 1 month, 4 weeks after your exposure, if your source is positive. Please begin the prophylaxis within 2 hours, preferably, but not later than 72 hours. After 72 hours, it's useless. Safety precautions, control policy. The hospital should have an infection control policy and team. Education, how to handle sharps. Vaccination for hepatitis B, and knowing your titer are very important steps. Also, safety precautions like devices which are safer. Conventional devices compared to devices which have a cover, which protect you from injury, should be used. Okay, so with this, we finish the class. I have some clinical cases, but I don't want to discuss them now. Okay, I can discuss them in a minute if it's okay. So, this is a patient who had a needle stick injury, and the source could not be traced of the HIV of the source patient, who was lost to follow-up. And he has a good amount of bloody injury. So what do? No prophylaxis, 1 drug, 2 PEP, only after knowing the source. I would go for 2-drug PEP. I won't take a chance here. At least give a 2-drug PEP. In case 2, this source patient turns out to be HbSAg. You can actually do these cases yourself. It's very simple. Okay, you do these cases yourself, I think, and try to work out the answers. Okay, there are 5 cases. Do them, and we can discuss them once. If you want, you can come and discuss with me these cases in person. That's better, I think. Thank you so much.